This is a case of a 38-year-old man with a history notable for intermittently controlled HIV, not on antiretroviral therapy at time of presentation, homosexual contact, and bipolar 1 disorder, who presented to clinic for chronic left lower quadrant pain and diarrhea. For the past 9 months, the patient had been having 10 to 20 non-bloody, non-mucousy diarrheas per day. Upon presentation, outside hospital records were notable for 1 month earlier a colonoscopy that revealed colitis as well as a stool culture that was positive for cryptosporidium in the context of a CD4 count of 216. At this time, the patient was diagnosed with cryptosporidiosis and prescribed nitazoxanide that was never filled due to financial constraints. Upon presentation to our clinic, his symptoms had reported no improvement. Family history was unremarkable, and labs were notable for a CD4 count of 386, making the diagnosis of cryptosporidiosis feel less likely. He was referred to gastroenterology and eventually underwent colonoscopy about 6 months later. Colonoscopy showed mild erythema of the colon, as notable in the middle of the screen, and biopsies revealed intestinal spiroketosis. Now, this was able to be diagnosed via pathology slide, as seen on the bottom. You can see at the top of the screen near the epithelium, there's this haziness that's known as the prominent false brush border that is characteristic of intestinal spiroketosis due to the Brachyspira species. Additionally, at this time, he was positive for Shigella. He was discharged with ciprofloxacin and metronidazole in order to treat both the Brachyspira, the metronidazole, as well as Cipro for the Shigella. He did not complete these treatments about a month later when he followed up with us and was noted to have mild improvement. 2 months later, he followed up again after having completed the treatment and had mild improvement, but the symptoms of diarrhea were still present. So now this brings us to our discussion points. So Brachyspira is the most common cause of intestinal spiroketosis and is a common animal pathogen, notable for swine dysentery. However, its pathogenicity in humans is highly debated. It's very prevalent in certain populations. Up to 50% of men who have sex with men and 44% of patients with HIV will be positive for Brachyspira. Now, some studies suggest that it is not pathogenic. Notably, a study of 760 controls and 460 patients with presumed gastroenteritis were tested for Brachyspira, and the rate of positivity was equivalent between the two groups, making it feel like a less likely etiology. However, other studies suggest it may be. For example, there's a case of bacteremia in a patient in shock, as well as studies where patients are PCR positive, have diarrhea, receive treatment with metronidazole, diarrhea improves, and PCR positivity goes away, therefore suggesting it may be a cause of their symptoms. Further complicating the story is that it's also highly implicated in irritable bowel syndrome, another common cause of chronic diarrhea. So our patient is the right population, a man who has sex with men, HIV positive, as well as demonstrating characteristic symptoms. The challenge being that he was also positive for Shigella, which was treated, and he had mild improvement after treatment with metronidazole. However, his symptoms did persist. So it is difficult to assign whether his symptoms were due to Shigella, due to Brachyspira, or due to a completely different etiology. So, what are the learning points that clinicians should take away from this case? First of all, in cases of chronic diarrhea, Brachyspira should be a less common etiology on clinicians' differential. Upon diagnosis via colonoscopy, clinicians should be aware that this may suggest a chronic infectious gastroenteritis, irritable bowel syndrome, or maybe an incidental finding. And prior to immediately jumping to treatment with metronidazole, clinicians should fully rule out and be considering other potential etiologies. However, if they feel that these etiologies have been appropriately evaluated, they may choose to treat Brachyspira with 500 milligrams of metronidazole twice daily for 10 to 14 days. Thank you.